Welcome to the operating table, the podcast where you get to ask the doctor all the questions. Actually, I do. But you ask the doctor and get to know all the things you wanted to ask, never thought to ask, or couldn't ask when you were in your doctor's appointment. Today, we're with an acclaimed urologist, Dr. Richard Vanlangendonck. We're going to call him Dr. Van because that's just too much to say, Vanlangendonck. But he goes by Dr. Van to his patients and the nurses. And we're going to start off talking about one of his areas of expertise is prostate cancer and robotic surgery. Robotic surgery's come a long way since the early 80s when the robot was in as the dance. It's now part of surgery we use for pelvic surgery, for GYN, and for prostate surgery. So, welcome, Dr. Van. How you doing?
I'm doing well, thank you.
Thank you for coming today. Let's talk a little bit, before we start talking about these fancy things. You hear these things about prostate cancer being a livable type of cancer. And in more recent years, people are saying, well, should you really get these PSA or prostate-specific antigen tests every year to test if you're a male? Just talk about prostate cancer in general. Is it something that you can live with? Is it something that you can't live with? Should people get tested? Should people get the blood test? And what are your thoughts on that? Because it's gotten more controversial over the years.
You're right. The main thing with PSA and whether we should screen for prostate cancer is, you're right, it is debatable, but a lot of the data that the United States Task Force used to calculate or try to come up with that answer was a bit flawed because it's basically retrospective data and not prospective studies that were looking at of the value of PSA. So, but we still see a lot of prostate cancers that are high risk or aggressive that we do treat. So the short answer, I believe we should screen for prostate cancer. But on the other hand, what we were finding with everybody who had a PSA and everybody who had prostate cancer, regardless of the grade of the cancer, was getting treated in some form or fashion. That has changed. So now, with knowing what we know about lower grade prostate cancers, Gleason 6 prostate cancer, what we determine now is favorable risk prostate cancer, a lot of patients can live with these.
Sure.
Whether they're young or old. And then there are some, though, that have higher risk prostate cancers that we do need to treat. So I feel that the PSA is a simple blood test. We get it, then we maybe move forward with biopsy to try to diagnose a patient with prostate cancer, but then make an educated decision. Not everybody needs to be treated.
Gotcha.
There's a lot of side effects with treatment of prostate cancer that can really affect a man's lifestyle, and so it's not something to be taken lightly. So we really only want to treat the cancers that need to be treated. So I think that we should continue to screen. I think it's valuable. There are a lot of patients that we will find, and I see in my practice, that have aggressive forms of prostate cancer, and their PSA really wasn't that bad or that high, and if they hadn't been screened, they never would have been able to find that strain, if you will. So I believe we should screen for prostate cancer.
Yeah, I look at it as being, having a little bit of education as a doctor. Mm-hmm. Would I want to know if I have cancer? And the answer is absolutely, okay?
Correct.
And then we can make the determination on the treatment, whether it be a prostate cancer, whether it be a breast cancer if you're a woman, or colon cancer. I'd certainly want to know.
Right.
And, you hear studies talk about, 98% of people. Well, somebody's in 2%. I mean, you go to a football game and there's, 2% of 100 people and you're 60, 70, 80,000. I mean, that's a lot of people who can be harmed. So if I could summarize what you said, and correct me if I'm wrong, a lot of people always do because I'm often wrong, but is essentially the blood test that you get will determine if it's elevated, you may have prostate cancer. And you may have prostate cancer that, you go and take a biopsy, which just take a piece, okay, so that you can determine what type of cancer it is. Some require treatment, and then some require observation, which is serial blood tests. But you can't tell based on the blood test alone, so that's why you have to do the biopsy. But not all of them necessarily require an aggressive form of treatment. If it's a benign or a less malignant cancer, you may be able to live with it for a long time and simply observe it. Is that correct?
That's correct. That's correct.
Okay.
I mean, there's a lot of patients I have now that when I first started practicing and 2003, we were treating, and now it's 20 years later, and I would tell you sometimes patients come in with low-grade risk prostate cancer, and they want to be treated, and we have to kind of steer them the other direction. Say, look, you really, it's not a good idea. You really don't want to do that unless you really have to. And I tell men all the time, hang on to your prostate if you can. So because it's not necessarily something vital, but it also will. But it can really affect your lifestyle, and so that's why we sometimes have to actually steer them away from treatment. And then other patients, you may have to steer a little more towards saying, look, you've got an aggressive form, you're not really a candidate for observation, or we need to treat this. If you don't, there's something bad's going to happen.
Sure.
The other thing about getting back just a little bit about PSA, it's. What most people maybe don't understand, or maybe they do, but it's a screening test. And the way I try to explain that to patients is that it's just like you going fishing, and you're catching fish, and you're going to have some throwbacks. It's a big weight a net, and you're just trying to catch everybody and not miss anything.
Sure.
But some people aren't going to need to be treated. Some people aren't even need to have anything done, and you just monitor them. But it's a simple. It's a very simple blood test, but when you find the guy who's got the aggressive form, who really would benefit from that treatment, then that's the guy that you really,
sure.
You're glad you did it because you caught it early and you're able to do something about it. And then the other thing about, we have these genetic germline, tests that we can do even on some of the lower risk or questionable patients, meaning that let's say they have, we kind of break prostate cancer down to a low risk, intermediate risk, high risk kind of category.
Sure.
For general purposes. And then we would do, on some of those intermediate risk patients, you can subcategorize them into favorable or unfavorable based on their genetics. And sometimes somebody who has an intermediate risk cancer that you would normally say, hey, I think I ought to treat this guy, you can do these genetic tests maybe will help you say, hey, well, this is really not a bad cancer. The genetics on it, the gene, testing on it says, hey, it's pretty favorable. On the other hand, sometimes you can find someone who you think you might want to treat, or I'm sorry, you may find someone that you didn't think really needed to be treated. They were fairly on the lower spectrum of that intermediate category, but the genetic testing says otherwise.
Says it may be worse.
Right. So and then you have the conversation, do you want to treat it now? Which we would recommend,
sure.
Or do you want to wait? And at least you can have again, it's all about information and being informed about and understanding the disease that you have, just
sure.
like with anything else. And once you have that, then you can make your best decision on what you want to do as an individual.
To treat it. So just so everyone knows, when you start to use the terms malignancy or higher grade, that means cells are growing more rapidly.
Right.
That's an aggressive kind of cancer that can grow and potentially spread. We use the terms benign or less aggressive, those that can be contained. So let's walk through this. So I'm a patient in your office, and I'll come in, and Dr. Van, my PSA is elevated, and you're suspicious that I have prostate cancer. Everybody hears the term cancer. Walk me through what you would tell me and how we would approach it, because that's important.
Mm-hmm. So, if say you came in with a PSA that is elevated, and it could be normally what we would see in the clinic typically is a PSA somewhere for an elevation is somewhere between say 4 and 10.
Okay, and what's normal so everyone knows?
Normal is on a scale is less than 4, but that's a little bit of let's put it this way. It's not exactly 100% cutoff at 4. I mean, some men who, if you're in your 50s, you can use age-adjusted ranges where your PSA maybe it's 2.5 for a 50-year-old white male.
Gotcha.
We tolerate a little bit higher for black men. Tend to have a little slightly higher PSAs. On the other hand, also we look at ranges. What's really more important when you're talking about the lower PSAs is as opposed to just one number, looking at progression over time. So if you came up and said, hey, my PSA was 1.7 2 years ago, now it's 2.5, now I'm 3.2, I'm gonna get a little nervous that even though you're still less than 4, you could be at risk.
A little more aggressive investigation.
Right. And
so
also with just on that, and if you told me, hey, I have a family history of prostate cancer,
Sure.
then I'm going to be a little more aggressive with you as far as recommended biopsy. If you're African American, that's another high-risk category.
Sure.
Then you would have, we may be more pushing towards the biopsy range.
Sure.
Or biopsy as treatment.
So let's assume I'm at, I walk in, I'm at 7.8.
Mm-hmm.
So what do you tell me?
All right, so you walk in on your PSA 7.8. I'd ask you if you had any previous ones just to try to compare.
I've been normal, and this is all a shock to me, and
Right.
I have to get on with my life, so I'm not dying, right?
And this is
That's the first question everybody has.
And this is Dr. Najib Thomas coming in 40.
No, this is not Dr. Najib Thomas. This is anyone off the street, patient X.
But I've got a young guy, is what you're telling me.
A young guy,
Right,
say.
right, okay,
I won't
so
disclose my age. Relatively young.
Less than 65. So I would tell you that
I'm less than 65 for
I
the
got you
record.
there.
Thank you. Okay.
I would tell you that your PSA is definitely elevated, and if it's been, if it was previously normal, now I'd be like, I would talk to you, say, hey, do you have a family history, any other risk factors for prostate cancer?
Nothing. I'm just scared.
Right. I would tell you, I need to do an exam on you. Okay, and you're going to go, and most people are like, oh, they still do that? Yes, we still do that.
So assuming I don't run out the door at this point, that's a rectal exam, right?
Exactly. A
Stick the
rectal
finger,
Right.
I don't need to describe it. Everybody knows what that
do a
is.
digital rectal exam, see if I feel anything. If I feel something, I'm already telling you, hey, we're probably going to do a biopsy. If I don't feel anything, then I would tell you, hey, look, I think you're at risk for prostate cancer, and we probably need to do a prostate biopsy. I would discuss with you, there's another test that we sometimes use now for elevated PSAs, and that is an MRI of the prostate.
Okay, yeah, tell us about that.
All right, so prostate MRI has kind of come into favor over the last maybe 3 years or so with evaluating an elevated PSA. What it can show you is it's a specific protocol. It's not just, you can't just do it at any center or any type of MRI.
Not just cramming you in the magnet, huh?
No,
All right.
and it's not an open MRI. People always ask me, okay, I'm claustrophobic. You got to go in the tube. So, but there's ways you can go. You can go in feet first. There's a couple of ways around some of the claustrophobic issues that people have.
Couple of beers beforehand.
Right, exactly. So we would tell them, you get an MRI of the prostate, specific protocol for prostate cancer, and what that does is it tells us if there's a scale that the radiologist will use that will tell us if there's a lesion that looks suspicious for prostate cancer, and then they're actually able to give it a score, not the Gleason score. Has nothing to do with the pathology score, but how likely the spot is to be cancer. Okay, so let's just say 3 is 1, 2 are low risk, 3 is a coin flip, 50-50 shot. A little on a 4, more likely a 70%, and then 5 is 90 to 100% chance it's going to be prostate cancer.
Okay, so what you're talking about is I come in with my 7.8. You say, hey, we can't let this go away. There's either sticking a needle, which is biopsy, or another diagnostic test, right?
Right.
This diagnostic test is the MRI, and being a neurosurgeon and interpreting MRIs, I'm telling you what we'll do is this will be interesting. So the radiologist comes back and says, Dr. Van, it's certainly more than a 2, but less than a 3. We really can't confirm because the images weren't great. So now what do you tell me? I always give you the tricky question. 7.8, and it's not a 3, but it's almost a 3, but more than a 2.
Well, what I would tell you is we need to move forward with the prostate biopsy. What we can do is if the spot on the MRI comes back 3 to 5, we will target that area. We will take we're able to take the MRI, load it into a system called there's different types of MRI fusion systems that we can take the MRI, load it into this, and then while we're doing an ultrasound, that's how we do a biopsy, is we put an ultrasound probe in the rectum, do needle biopsies of the prostate. But with the MRI, we can actually overlay, with the fusion software, we can overlay the MRI on top of the ultrasound. So it's sort of like a GPS.
So you get like a GPS guided biopsy. Okay.
Right. So essentially it's something that you would probably be familiar with neurosurgery, but similar type of things so that we can hit that specific target.
Okay. So just for cancer diagnoses, what we're talking about is you have this, elevated PSA. It's a good screening tool, in your opinion. When you get an elevated PSA, we get more diagnostics and potentially a biopsy. And then in our next podcast, we're going to talk about the biopsy coming back and our options, and we'll go from there. So thank you so much.
All right. You're welcome.